All right, class, welcome to chapter 9. We're going to be talking about articulations or joints in this chapter. And as always, here are the learning outcomes at the beginning of the chapter. Make sure that you can understand these and talk about these before your exam. And one more page of learning outcomes. Okay, so what are articulations? What does that word mean? It simply just means joints. So where two or more bones come together, that is a joint, and also known as an articulation. So obviously we learned the 206 bones of the skeleton. The majority of them by far, other than that hyoid bone, articulates or joins with another bone, right? So we're going to be talking about all the different examples throughout the 205 bones that actually touch other bones. And as you can see in the notes, they permit bone growth and enable the body to move. So we're going to spend the next two chapters on the muscles and how muscles move, but muscles are kind of useless if the joints aren't healthy, right? If you dislocate a joint, for example, if you dislocate your knee, you're probably not going to be walking on that knee. So the bones need to be aligned in order for the muscles and tendons and ligaments and everything else to work properly. So let's get started. All right, everyone, very, very important slide here. This slide is kind of going to lay down the foundation for this entire chapter. If you understand these big key words at the bottom of the slide or the middle of the slide, that will greatly help your studying and your organization with all of these joints. So two ways of classifying joints. We can classify them by their shape or by their structure. Basically what that's saying is their anatomy. What are these joints made up of? What do they look like? And you can see this is the anatomy description right here. So I'll talk about those in just a second. The other way we can classify joints is by what do they do, their function. And we're going to have three different functional classifications as well. So yes, shape determines function, right? We've been talking about this since we first met, day 1, chapter 1. Shape determines function, and it's no different in the joints. And you're going to see that the shoulder joint is a little different than the hip joint, which is different than the knee joint, and they're all going to work a little differently. So let's dive into these classifications and kind of give you an idea of what we're talking about here. Let's talk about the green ones first. The green ones are the functional classifications. The first type of joint is called a synarthrosis, or if it's plural, you can see it's spelled synarthroses. And these are immovable joints. So picture a great example are the sutures in your head, right? We learned about all the lambdoid suture and the coronal or sagittal suture, the squamous suture, all that stuff. Those don't move, so that's an example of a synarthrotic joint. They do not move. A diarthrotic joint, or diarthroses, does move. It is freely movable. Picture your elbow, your shoulder, your hip, your ankle. You can move it in multiple directions. And then amphiarthroses, if anybody's ever been to an amphitheater, it's a half theater, right? It's not a full stadium dome type thing. It's just the stadium wraps around halfway around the stage and there's no backside. So it's kind of in between. So I'm going to put half, but it's not really half movement. It's just a little bit of movement, but not full free range of motion for the amphiarthrotic joints. So once again, that's the function. What do they do? Some move, some don't move, some move just a little bit. Let's move on to the red structures, the underlined in red structures. This is how we're going to classify the anatomy. What is this stuff made up of? So you can see the synarthrotic joints are made up of what we call fibrous joints and cartilaginous joints. So the fibrous joints are going to be made up of fibers, right? We've been talking about different protein fibers, mainly collagen fibers or elastic fibers. Collagen is going to be our main theme here. And then what do you think a cartilaginous joint is made up of? Yeah, exactly, cartilage, right? Nothing crazy there. So it can be either or. I'm going to tell you about the exceptions down the road. But for the most part, the majority of your synarthrotic joints are going to be fibrous. We're going to have big collagen fibers holding these things together. Moving down to the amphiarthroses, or the amphiarthrotic joints, that can move a little bit. Same thing, you're going to have both fibrous and cartilaginous, but for the most part, they're going to be cartilaginous. They're going to be made up of either hyaline cartilage or fibrocartilage. And I'll give you the examples in just a bit. Last but not least, we have the diarthrotic joints, or the diarthroses. And this is a new term we have not discussed yet. These are made up of synovial joints, or synovial capsules, if you will. And what that means is there's like a bubble between the bones. There's actually a cavity, and it's filled with fluid. And the fluid's actually called synovial fluid. So very different than the other two. Synarthrotic joints are mainly fibers, mainly collagen proteins. Amphiarthrotic joints, mainly cartilage. And with the diarthrotic joints, we're going to have a bubble between them. So just to kind of give you an idea, little spoiler alert, we have our, let's say, humerus bone and then our ulna bone. And then between them, we're going to have this little bubble connecting them, along with cartilage and ligaments and all that stuff too. But inside of here is going to be synovial fluid, lubricating the joint, keeping the joint healthy. So once again, I know I've spent a while on this slide. This is basically the foundation. If you understand this slide, everything else with your studying will be very easy, because you can kind of group all of the specific types of joints in one of these three. So every single joint has to fall under one of these three functional groups. Does it move? Does it not move? Does it move a little? And every single joint in the body has to fall under one of these three structural or anatomical groups. It's either made up of fibers, it's got to be made up of cartilage, or it's got to have this fluid in between. Can't be anything else. So let's continue on and dive into the specifics of each of these. Once again, structural classification of joints. This is just the anatomy, just a review slide here, nothing new. The three types, it's got to be made up of either fibers, cartilage, or that fluid-filled space called a synovial joint. And then we have the functional joints, same thing. Remember, with our synarthrotic joints, most of them are going to be fibrous. I'll give you the example of cartilaginous in just a moment. And then most of our amphiarthrotic joints are going to be cartilaginous. I'll give you the weird exception in just a moment. And then we have our freely movable ones down here, the diarthrotic joints, or diarthrosis. So a good way I always remember this in school is synarthrosis. If you sin, like S-I-N, you're in trouble, right? Your parents tell you to go in timeout, don't move. That always just for some reason stuck in my head. If you sin, you're not allowed to move. You're in timeout. So a synarthrotic joint does not move. And once again, a big example of that were the sutures. So no movement. And then the amphi, I gave you the example with the amphitheater, and then diarthrotic are just freely movable. Picture everything in your limbs pretty much. Fingers, toes, knee, ankle, wrist, elbow, and so forth. So once again, no movement, and the synarthrotic joints are held together by fibrous connective tissue, mainly going to be collagen fibers. The amphiarthrotic joints, mainly cartilaginous. A great example of this is the symphysis pubis, or the pubic symphysis, as you learned in lab. right? There has to be a little bit of movement there. It's holding your two pubic bones together. That's important, but especially with athletics, that has to have a little bit of flexibility, a little give and take, right? If we're skating or rollerblading or doing the splits, has to move a little bit, but also big time comes into play with the birthing process. If a lady is having a vaginal birth, that thing is splitting a little bit. It has to move to allow the baby's body to come through. So we're going to have a mixture. I know in your notes it says bones at these joints are connected by hyaline cartilage. Yes, that is true. Almost every joint in the body does have hyaline cartilage. Even the pubic symphysis has a tiny little bit of hyaline cartilage. But what we've talked about before with the tissues, the pubic symphysis is mainly fibrocartilage. So remember the three big places I wanted you to know was the pubic symphysis, the discs between your vertebrae, the intervertebral discs, and then the menisci or the menisci in your knees. So those are the three main locations. And even though they are mostly fibro, there is a little bit of hyaline along all of those joints. And then last but not least, the diarthrotic joints, once again, freely movable. You can see an example here. We'll talk about this in detail. The glenohumeral joint. What in the world is that? Well, you should have seen a glenoid process in your lab, right? And that's part of the scapula, or glenoid cavity. And then the humeral is the humerus bone. So this is where the humerus bone fits inside of that capsule, or that fossa, with the scapula. So this is your, what joint? If we're talking humerus and scapula. This is your shoulder joint, exactly. And there are 6 major characteristics, depending on what book you read. Some say 5, some say 8, it just depends. We're going to talk about 6 major characteristics with the diarthrotic joints in just a bit. Okay, so I would strongly encourage you to make a chart or a table or some flashcards, because now that we've introduced the 3 types of anatomical joints in the body and the 3 types of functional joints in the body, now we're going to dive into specific examples. And it can get a little confusing if you're just writing all this in order, but if you're kind of grouping it in categories, it's really, really simple. So first, we're going to talk about the fibrous joints. So once again, for the most part, these are going to be immovable, and they're made up of fibers. We're going to have some type of collagen protein holding these things together. So let's talk about the 3 types of fibrous joints you're going to be responsible for. The first one is called a syndesmosis joint. If it's plural, it's known as syndesmoses with an ES at the end. So these bones are held together by what you can see ligaments. And we talked about this in the tissues chapter and in the bones chapter. What is a ligament? A ligament is something that connects a bone to another bone, right? So a little different than a tendon. Tendon's bone, the muscle. So if you remember what ligaments are mainly made up of, it's that dense regular tissue. And remember, dense regular tissue was just a whole bunch of collagen fibers going in 2 different directions, right? Up and down, left and right, that kind of thing. So just reiterating the fact that these are mainly made up of collagen fibers. Now, this is that weird exception. I said that the fibrous joints are, for the most part, synarthrotic, or that those are synonymous. Synarthrotic, not moving. Fibrous joints, yes. But I also said there's one kind of weird thing that where it can move a little bit, where it's amphi, and you can see in the notes, it kind of verifies that it's very limited movement. But it does move. So to call this synarthrotic would technically be incorrect. This is a little tiny bit of amphiarthrotic movement. It doesn't move much, but it does move. So that would be the one weird exception. So where do we find these things? This is found between 2 long bones in your forearm and the 2 long bones in your lower leg. So an example here, the joint between the distal ends of the radius and ulna. Between the radius and ulna, you have ligaments. And once again, we're talking ligaments here, made up of collagen fibers, stabilizing this. So everybody kind of shake out your wrist, pump your wrist, move it from side to side, up and down. We're going to learn all the different terms: flexion, extension, adduction, abduction in just a bit. Spin them like you're pouring out something, like if you have a bowl and you pour out a bowl or pour a cup and stuff like that. There is a little bit of movement between the bones. You can feel the bones move, and in between them there's a tiny bit of movement. So this is referred to as a syndesmosis joint because it is touching two bones together. Another example is between the tibia and the fibula near your ankle joint. Same thing, you got this ligament connecting these two bones. As you walk, run, go up and down the stairs, there is a tiny little bit of movement. Not much, but it is a small amount of movement that gives your ankle great mobility. The next type of fibrous joint you're familiar with, and you actually already know all four of them, or the four main ones, right? Sutures. So these are only found between the bones of the skull, and they're those kind of jaggedy, zigzag-looking structures between the frontal bone, parietal bone, occipital, temporal bone. And once again, it is connective tissue. It's a ligament. So therefore, same thing. It's just dense, regular tissue. And what is dense, regular tissue mainly made up of? Collagen fibers, exactly. Same ingredients. This is very, very important as we're growing up, as our head's getting bigger. Remember, those soft spots in our heads are called fontanelles. And as the fontanelles start to get closer together, they start to shrink, and the bones get closer together. We eventually ossify these, and they become bone-on-bone interlockings. But there are still collagen fibers in between them. Remember, your bones have collagen fibers inside of them, all that lamellae we talked about. Okay, and then the last type of fibrous joint that you're responsible for is called a gomphosis joint. And a gomphosis joint is only found in one part of the body, that is in your mouth. And what it is where your teeth go into your lower and upper jaw. So you can see the definition: a cone-shaped bony process, meaning your teeth go into a bony socket. So remember that we have two bones associated with the jaw, right? We have the mandible, but the mandible is only our lower teeth. So we have all those alveolar processes that we discussed in lab. All of your teeth that actually insert into your mandible are called gomphosis joints. But what's the name of the bone for your upper teeth? It's not the mandible, it's the maxilla, right? Or the maxillary bone, exactly. So we have them in both maxillary and mandibular bones. And they are also held in place by ligaments. You're seeing a theme here. Ligament, ligament, ligament. So also collagen fibers holding these things together. So the sutures are immovable. These are synarthrotic joints. Remember, if you sin, you're in trouble. Go to timeout. Don't move. You can't move your head. You can't move your parietal bones where they meet with your temporal bones. If you can, we got a problem. Gomphosis joints in a healthy person should be synarthrotic. Your teeth should not be moving regarding the actual joint with the mandible or maxilla. Your teeth can maybe have a little tiny bit of wiggle room. That's more of like a gum thing possibly, but they shouldn't be moving inside of the bone tissue. That's we got some periodontal disease or something even worse than that if your teeth are moving. So your teeth should be strong and staying still, right? So once again, charts, tables, graphs, anything to help you organize this. These are the three types of fibrous joints, all made up of some type of ligament. Great illustration for you visual learners out there. These are really, really good pictures. You can see on the left we have the sutures in the skull. The middle picture, you can see the ulna and the radius, and you can see that ligamentous tissue between the two bones, anchoring them together. So when I do a push-up or when I open a door or something like that, my bones don't bow out. They are held together by these strong ligaments with a little tiny bit of movement. And then on the right, you can see the gomphosis joint, where you have a tooth and it's embedded in the bone. So here in the pink, you can see the gum line But deep, deep down inside, you can actually see bone, and you see all the holes there. So remember, that's a spongy bone, right, or cancellous bone. So these are considered joints because we are talking about bone to bone. Let's move on to the next type of anatomical joint, which is going to be the cartilaginous joints. All right, there are two types of cartilaginous joints that you're going to be responsible for. One is going to predominantly be full of hyaline cartilage, and the other one is predominantly full of fibrocartilage. So the first one I want to introduce is the synchondrosis joint. And this is going to be the one that's going to be mainly made up of hyaline cartilage. And as you can see in the second bullet point, it says many of these joints are temporary structures that disappear as a result of growing. So what that's referring to is, you should know the answer. We covered this in chapter 6, right? This is the hyaline cartilage, or the growth plate, the epiphyseal plate. So you can see that the epiphyseal plate kind of goes hand in hand with the name synchondrosis. Remember, a synarthrotic joint doesn't move, and then chondro means cartilage. So these joints don't really move, but they do help your bones grow. Another example is the costal cartilage that we covered in lab and lecture. This is what's connecting all of those ribs, true and false, to your sternum. So there is a little bit of movement with that, right? Take a really, really deep breath. That cartilage can expand. Your rib cage has to move just a tiny bit. So you can make the argument that the costal cartilage can be considered an amphiarthrotic joint. The next type of cartilaginous joint is a symphysis joint. And the symphysis joints are going to be mainly fibrocartilaginous. So remember what fibrocartilage is. It's cartilage with a lot of collagen fibers. So this is the really, really, really strong stuff. So remember the three major locations that we talked about where fibrocartilage exists. Most are in the midline, right? You have your intervertebral discs in the middle of your body. You have your pubic symphysis in the middle of your body. And then the other example that we talked about was the meniscus or menisci in your knees. Very, very strong joints. So this is once again where we can get kind of picky, where these joints for the most part are amphiarthrotic. The pubic symphysis has to move. Your intervertebral discs have to move a tiny little bit. The meniscus in your knee has to move just a little bit. The example of a synarthrotic joint, as we already talked about, is the epiphyseal plate. When you're kids, you can't move the epiphyseal plate. It's kind of like a suture. It's kind of just held in place. So those are the two types of cartilaginous joints, synchondrosis, symphysis. Let's move on to the next slide, and I'll show you a picture of them. So here you can see a really good picture on the left with a bone with the growth plate, the epiphyseal plate. So obviously this is still a child or a teenager. And once again, that is temporary. It will eventually become completely ossified when that kid is done growing. And then you can see that fibrocartilaginous joint, the pubic symphysis, holding those two pubis bones together. So this would be a synchondrosis joint on the left. And then it would be pubic symphysis, kind of makes sense. This would be a symphysis joint on the right. All right, so we've covered fibrous joints, we've covered cartilaginous joints. The last type of structural joint in the body is a synovial joint. And once again, these are the freely movable. These are what we call the diarthrotic joints. And the reason why they are freely movable is because they have this fluid-filled pocket or capsular bubble between the bones. So take your fingers, and some of you are really good at this. You pop your fingers or pop your toes, right? Just kind of pull on them or crunch them a little bit. And a lot of that is just nitrogen gas that builds up in between those cavities, those sockets. Just don't do it too much, right? Don't extend your joints. So by far, these are the most numerous and most complex joints as well. We're going to talk about how crazy the shoulder, hip, and knee get later on down the road. But these are the most numerous because where you find synovial joints are primarily in the limbs. So start from your shoulder and work distal. So your shoulder joint, then you go down to your elbow joint. The elbow bones are connected to the wrist bones. The wrist bones are connected to the hand bones, the finger bones, right? All of those joints are synovial. They're freely movable. Even the tiny little wrist bones between them are synovial joints. And then same thing, we can start with the hip and just work our way distal. The hip is synovial, fluid-filled. The knee is fluid-filled. The ankle, and then all the tarsal bones. You learned about the talus bone and the calcaneus bone. All the joints between all of those bones are all synovial. And then, of course, you have your metatarsals and your phalanges. All of those are synovial joints. So because we have so many fingers and toes and wrist and ankle bones, this makes up a really large number. So limbs is mainly where you find this. And you can see some new terms that we're going to discuss. We're going to talk about the capsule in just a little bit. We're going to talk about the synovial membrane in just a little bit, and also that synovial fluid as well. But you should have seen articular cartilage before, right? This should look a little familiar here on the left. That articular cartilage is this cartilage that lines the bones. And remember, when in doubt, what type of cartilage are we talking about? 9 times out of 10, it's going to be hyaline cartilage. Exactly. Okay, so at the beginning of this chapter, I talked about there are 6 characteristics with synovial joints. Well, here are a few of them, and then I'll show you a picture and we'll cover the other 2. But unique to synovial joint, which means that the fibrous joints don't have these, and the cartilaginous joints don't have these. So let's talk about what these things are. Number 1, the joint capsule, or also known as the articular capsule. What this is just a continuation of the periosteum between the 2 bones. So remember, periosteum is just the outside part or outside covering of bones, mainly made up of collagen fibers. You name it, you got it. And the capsule kind of works as like a barrier or a wall to the outside of the joint. So we don't have any blood vessels for the most part inside of these joint capsules. Now I'll talk about the knee and how that's a little weird in just later down the road. But for most of these synovial joints, we don't have any blood flow in there. So in case we do have a toxin, say we have food poisoning, it's not going to get inside of our joints. So it's kind of barricading the joints from the rest of the body here. It's made up of dense irregular tissue specifically, so regardless, it's still collagen fibers. And it's really just kind of making the outside of this bubble or this capsule. Now, lining the inside of the joint, we have 2 things. We have the cartilage, which we talked about is already hyaline cartilage. And then we have this new term called a synovial membrane. And the synovial membrane are specialized cells wherever there's cartilage not present. And what these cells do is they actually secrete this synovial fluid. So the synovial fluid is really, really cool. A lot of neat things that it does. Number 1, it lubricates the joint. We want to be able, make a fist and move your toes. We want to be able to move our fingers and toes and shoulder and head and neck without constant popping, crunching, cracking noises, right? So what's keeping that from happening all the time, every time you move your jaw or your fingers, is this synovial fluid. It's lubricating the joint, hydrating the joint. Another function of synovial fluid is metabolically, they secrete a lot of sugar. They secrete a lot of glucose and nutrients into these capsules so the hyaline cartilage can stay healthy. Because remember, hyaline cartilage down here, this articular cartilage, doesn't really have good blood flow. So we've talked about it several times in class where if you damage cartilage, you're that's not good, right? Sometimes you're never the same. So regarding our cartilage lining the joints, hopefully we can keep these things healthy as long as possible. And one way we do that is the synovial membrane secretes nutrients into the joint. And then the last thing is shock absorption. If you think about just running, I went for a jog today, and just the pounding. Just think about your feet alone. Don't think about any other joint. Your feet, your ankles, just that constant pounding between those bones. That is traumatic. That is a trauma. That is a stress. So we need protection, and we need shock absorption, and that fluid kind of helps with that too, and not just in the ankle, but also knee and the hip and everywhere else too. So the synovial membrane kind of works like a sponge. It's really cool. As we're going along through our day, say when you're going up and down the stairs, the sponge kind of gets squeezed, and that synovial fluid gets leaked out. And remember, that's a good thing because we want hydration and lubrication and nutrients. But when you stop moving, the synovial fluid can kind of get sucked back into the membrane and used for later. So we kind of recycle this stuff, so to speak. And if you've ever heard the term motion is lotion, if somebody's got some weird stiffness going on and they say, well, walk it off or do this, this is why that can be very, very true for some folks, is the synovial membrane. The more you move it to an extent, you don't want to overkill it, right? That can create injuries as well. But the more you move your joints, generally speaking, the healthier they are. So the articular cartilage, we've already talked about that. It's going to be hyaline cartilage cushioning the joints, giving us that nice slippery, slidey surface. So once again, our bones don't crunch, crack, and pop every single time you move. And then we have the joint cavity, and the joint cavity is just the space in between the bones, and that's where all that synovial fluid is going to be swimming in. So let's go on to the next slide, and I'll show you a picture and try to point all these structures out for you. So here we have that same picture as earlier, just a nice joint, and you can see, just a little side note, sidetrack, you can see here that there's a scar between the diaphysis and the epiphysis, right? There's no cartilage here. So remember, what we call that is the epiphyseal line. So this is an adult joint. This person is no longer growing. There's no growth plate. All right, first let's introduce the capsule. So the capsule, as I mentioned, is a continuation of the periosteum. So if you look right here with the purple arrow, here is the outside of the bone, and you can just kind of trace that along to the other edge of the bone, and then we can do that again on the other side, bone connecting the bone, and you can see how it kind of creates this bubble or this enclosed space. That's the purpose of the capsule. Now, don't get the capsule confused with ligaments. Ligaments are going to be a lot bigger, and they're going to be more on the outside. It's still connecting a bone to bone, but a ligament is going to look more like this, holding those things together. So the articular capsule is just surrounding the capsule, or the joint cavity itself. Okay, the synovial membrane is inside of the articular capsule, anywhere where we don't have cartilage. So you can see the hyaline cartilage in purple here is lining the very edge of the bone, or the edge of the epiphysis. And then this area in red is the synovial membrane. So it's basically kind of the inner lining of the capsule. And as I mentioned earlier, it kind of works like a sponge. It's going to be leaking out that synovial fluid into the synovial joint cavity. So this area in green right here is going to be our joint cavity full of fluid. And then, what am I missing? Capsule, cavity, and the cartilage. We covered the cartilage. Cool. So those are the four things from the previous slide. Last two things that are unique to synovial joints are the ligaments and the bursae. Now, ligaments, remember, were found in those fibrous joints, though. The things holding your head together, the sutures, the gomphosis joints with your teeth, also the syndesmosis was specifically ligaments. We do find those in fibrous joints, but we do not find ligaments in cartilaginous joints. So we do consider this somewhat unique to synovial as well. And then the bursae, or bursa singular. So what a ligament is you already know. It's just a whole bunch of collagen fibers connecting a bone to another bone, so between bones. And it just helps hold everything together. Just stabilizes the joint, makes everything strong. Now, what is a bursa? A bursa is formed from the synovial membrane. So it's this kind of pill-like, sac-like structure, this kind of bubble inside of the joint cavity that's filled with synovial fluid. So the synovial membrane is filled with synovial fluid, and the bursa is filled with synovial fluid. So remember, the purpose of the synovial membrane or the synovial fluid is mainly lubrication, shock absorption. So if you have a bursa inside of a joint, you just have more protection, more shock absorption, and more lubrication, more hydration for that joint. So we find these kind of all over the place. They're not present in all synovial joints. For example, you don't have them between your fingers and toes, but you do have several in your knee. You have a few in your hip. You have some in your shoulder, your elbow. If anybody's ever had bursitis, typically the most common area I would guess would be the knee to get bursitis in. If you ever had your knee drained and they stick a big old needle in there and just clear fluid comes out, mainly that's synovial fluid because the bursa is inflamed and it just keeps on pouring out synovial fluid inside the joint. Also, if anybody's ever gotten a hip pointer from falling on their hip bone or hip socket, you can get hip bursitis. It's the same thing. These things just get swollen and they start secreting too much fluid, which sounds like a good thing, right? Too much lubrication, too much hydration. But remember, we're talking about a cavity. We're talking about a bubble, a space. So we can only put so much fluid in there. If it starts filling up, it's going to cause pressure and a lot of pain. So let me show you on the next slide what a bursa looks like. So here we're looking at the knee joint. From a lateral or from a side view, you can see the proximal bone on top. This is the femur. And then down here would be the tibia bone. And here's your kneecap, your patella. So the bursae, or the bursa of the knee, you can see one right behind and above the patella in purple right here. And once again, what this is just a pillow-like sac. It's a continuation of the synovial membrane. So it's just a big bubble full of more synovial fluid. That's called the suprapatellar bursa, right above the patella and kind of behind it. You also have one right in front of your kneecap called the prepatellar bursa, and you have one underneath as well. So you have several bursae. Not everybody has the same anatomy, but several bursae in your knee joint, and it's just extra padding, extra protection. So when you're crawling on your knees with your kids or something, or a toddler on the hardwood, you have a little extra cushion and lubrication in those joints for you. All right, so we have covered all three types of joints. So we've covered the fibrous joints and the cartilaginous and the synovial. And remember, most fibrous are immovable, so we call those synarthrotic joints. Most cartilaginous joints were a little bit movable, it's kind of halfway in between, so we call those amphiarthrotic. And then we just finished the synovial joints, and those are freely movable because of that synovial bubble, that capsule, that cavity. So those are what we call diarthrotic or diarthroses joints. So now that we have the anatomy and the physiology down for the joints, we can talk about specific movements with these joints. And for you exercise, physical therapy assistant, and PT and ortho folks, this will be a little more interesting for you. So several different movements that can exist in the body when we're moving our fingers and toes and head and neck and spine and all these things. And what we're going to do is classify these specific movements. So the first few movements that we're going to discuss are called angular movements. And picture a protractor or a right angle, a 90-degree angle, and with your body. So like if you make a field goal with your shoulders and elbows, you make a 90-degree angle. We're going to be moving our arms and fingers and toes and legs in different directions that create different angles. So let's cover these first two. These are opposites. So we have flexion and extension. So if I flex my knee versus extend my knee, I'm doing a totally opposite direction movement of the knee. So with flexion, key terms here. Notice how it's bolded. You're decreasing the angle between the two bones, and a really, really great way, I always remember this in school, is you're bending a joint. So you can flex your elbow and you can extend your elbow. If you flex your elbow, you're bending the elbow. So flex your biceps muscles and you are flexing the elbow. Same thing with your fingers. As you flex your biceps muscle, you should probably be making a fist. When you curl your fingers in to make a fist, you're also flexing your fingers. You're bending the fingers. So if you all are sitting in a chair, you're also flexing your hip joints. You're also flexing your knees if you're sitting in a chair. If your knees aren't locked out, if your knees are bent, you're flexing the knee. So the opposite of flexion is extension. So if flexion is bending a joint, extension is increasing the angle and therefore straightening the joint or locking the joint out. So while you're sitting there at your computer or wherever you are listening to this, make your fingers as straight as possible, like you're giving somebody a high five or something like that. That would be locking out your finger joints. That's straightening your finger joints. So you are extending all your fingers. Now straighten your elbow. When you straighten your elbow, you are extending the elbow. Straighten out your knee. Make your leg straight. That would be extending the knee joint. So flexion is bending, extension is straightening or locking out. And you can see the picture on the right, the different examples. You can see flexion here with the knee. You're bending the knee. So this calcaneus, your heel, is going towards your glutes. And then extension would be where your knee is straight, locked. And you can see it also with the shoulder. The shoulder's a little funky. Because with flexion of the shoulder for the most part, the arm can still be straight, but when you're bringing it backwards, you're extending it, you're really locking out that shoulder joint. Flexion, you have a lot more range of motion. So let's keep moving and talk about other angular movements. So flexion extension is one pair of opposites. On this slide, we have another pair of opposites called plantar flexion and dorsiflexion. Now, very important though, you can have flexion extension everywhere, right? We just talked about fingers, knees, elbows. You can flex and extend your wrist. You can flex and extend your hips, even your head and neck. But these two movements right here, plantar flexion and dorsiflexion, only happen in one place in the body. And where's your plantar region found? Remember, that's the bottom of your feet, right? So this is only referring to your foot-ankle joint area. So you can see the picture where we're looking at a foot. So plantar flexion, what we're doing in plantar flexion is we are flexing or contracting the bottom of your foot. So make the bottom of your foot really tight and crunched up. And what you'll do in order to accomplish that is point your toes downward. And the way I always remember this was kind of your tippy toes. Say that you're walking on your tiptoes. That is the definition of plantar flexion. And if you walk on your tiptoes for 5-10 seconds, you'll feel that crunching or that contracting of that muscle and that fascia on the bottom of your foot. And it won't feel good if you do it a long time, right? So ballerina dancers, great example of this. They love, or they're really, really talented at balancing on their toes. And they are constantly in plantar flexion. So dorsiflexion is the complete opposite. Dorsiflexion, you're contracting the muscles on the dorsal part of the foot, so the top of the foot. So what you're doing here is sending your toes upward or superior towards your head or towards the ceiling. So what you do with dorsiflexion, extreme dorsiflexion, is you're walking on your heels. Also a very good exercise to help you warm up before a workout. To avoid shin splints would be dorsiflexion. Walk on your heels. Probably not good for your heels long term, but good for the muscles. So once again, only happening in the foot-ankle area. You can't have plantar flexion in your shoulder or dorsiflexion in your wrist. It doesn't happen. It's only in the foot. Other angular movements are abduction and adduction. I'll say that again real quick. Abduction, adduction, really similar terms. So what we like to do to make sure we don't confuse ourselves and each other is we enunciate these first two letters. So we say abduction and adduction. And that way we don't confuse each other. So abduction is, as you can see, movement away from the midline. So here's our midline. If I draw a mid-sagittal line down this gentleman's body, right, that's our midline. So if we're moving a joint away, such as this gentleman's arm, moving it laterally, that is what we call abduction. Same thing if we were doing something like a jumping jack and we were to separate the legs and the legs were to go out or lateral, that would be abduction. Not really nice and kind or creative, but if you think about abducting something, if you abduct a puppy or abduct a cat, you're taking the cat away, right? You're moving it away from the midline. Whatever helps you remember it. And then the opposite of that is a deduction. A deduction, you're bringing it towards the midline. So if we were to take this left arm and kind of tuck it in towards our waist, that would be a deduction. Or if we were to put our legs together, so where our legs are touching towards this midline, that would be a deduction. So we've covered all the angular movements. We've covered flexion versus extension. We've covered plantar flexion versus dorsiflexion. And we just finished with adduction versus abduction. So once again, charts, graphs, kind of tables or pictures will help you organize all of these. Next topic are the circular movements of the synovial joints. So if you notice, synovial, we're talking about mainly our limbs, right? We've talked about bending the ankle, right? Tippy toes or walking on your heels, flexing, extending the elbow, flexing, extending the knee, and abducting the arm, adducting the leg. So mainly with these synovial diarthrotic joints, they're going to be found in your limbs. And same thing here for these circular movements. Circumduction is anytime you can move something in a circular pattern. So basically, if you do arm circles, right, just make a kind of a windmill looking thing and warm up your shoulders, that's circumduction. It's just moving anything in a circle. You can do this with your leg. You can make the argument that you can do this kind of with your thumb, move it around in a circle, thumb war kind of thing. That's circumduction. Rotation is a little different than circumduction because you can't make a full circle because it's rotating around a fixed point. So examples here you can see in the picture on top. You can rotate your head and neck, and that's basically saying no if somebody asks you a question. So you shake your head to the left, shake your head to the right, and that is rotation. So you can have left rotation and right rotation. Another type of rotation, you can rotate your shoulder by just simply moving it kind of towards the front and the back. You can also do the same thing with the hip socket. And what we would call that is same thing. It can be left and right rotation, but with the hip and shoulder, you can also say lateral rotation if your foot kind of kicks out to the side. And then if your foot goes inward, we can call it medial rotation. But your hip is stuck, right? It's inside of that acetabulum, so it's at a fixed point is the key word with rotation. Okay, and then we have supination and pronation, and these two are opposites. So I'll draw a little barrier right there for us, where circumduction and rotation are kind of their own things. Supination and pronation, some of you may have heard this with shoes. If you go to like a running store and you step on the medial side of your foot too much or the lateral side, they'll say, oh, you're a pronator, oh, you're a supinator. Yes, that does happen in the foot, but regarding joint movement, this only happens in the forearm area. So supination, pronation is how your foot strikes the ground. Regarding joint movement, which is what we're talking about, this only occurs in the forearm, the radius ulnar region. So supination is when, as you can see, moves your palms upward. So your palms are facing toward the ceiling. Basically hold a hot bowl of soup. Pretend you're holding a bowl of soup and put your hands together and kind of like cup it. That's supination. And then when you pour that bowl of soup out in the sink, or when you pour like a water bottle out on the floor, that would be pronation. So when your palms go down. So you should be able to supinate, pronate back and forth very easily. And it's due to these movements and also that syndesmosis joint between the radius and the ulna that we talked about earlier. Other types of synovial movements are gliding movements. Another type of description that we can call gliding is sliding. Gliding, sliding, kind of the same thing. Also slipping, very similar. So this occurs in areas where the bones are really, really small, and therefore they're not working individually, they're working kind of collectively as a unit. So the greatest example are the carpals and tarsals, and you can see in this picture here, we're looking at, well, y'all tell me, are we looking at the wrist or the ankle here? And hopefully what you're saying is the wrist. That is the correct answer. We're looking at the radius bone on top here. And then you got the styloid process of the radius going to the thumb side. And then this skinnier bone would be the ulna right here. So we're looking at the carpal bones. And now, I mean, look at them. We didn't make you learn them in lab, but there's 8 of them. And all these bones kind of work collectively as one unit. They work as the wrist. Right, so it's not one bone moving along one bone, and they all work together, and it's just a very subtle movement. It's still considered diarthrotic because there are cavities, there are joint cavities between every single one of these bones, but they're very, very tiny. So the movement is subtle. So we call these movements gliding, sliding, slipping movements. The other example that you see this in the body are in the articular facets. Remember, we had the superior articular process and inferior articular process in our spine. Once again, very, very small joints. You are allowed to move your spine, right? You can bend and twist and turn, but the movement at the spine itself is a collective thing. If you go down and touch your toes, you're moving every single joint of your spine pretty much. The articular facets can only bend so far, so they just kind of glide past one another. So wrist, ankle, and then parts of your spine. And the last type of synovial movements are what we call special movements. And we call them special basically because they just don't fit in any of the other categories. So instead of calling them irregular, we call them special because they are special. They are unique. We need these movements. And similar to previous comparisons, these are opposites. So inversion versus eversion is an opposite pair, and then protraction versus retraction is an opposite pair. So let's look at inversion, eversion. This only occurs similar to the plantar dorsiflexion. This is only going to be occurring at the ankle foot joint. That's the only place where you can invert or evert a joint. So what we're looking at here is somebody's left leg. So let me draw the right leg for you to give you perspective. And yes, I know I'm a great artist. So this is the right leg, this is the left leg, and therefore the pubic symphysis or the midline would be somewhere up here. So inversion is turning the sole of the foot inward or medially towards the midline. So you can see how the patient's foot or the client's or person's foot is in the middle here, and then as they turn it inward, kind of like if you roll your ankle, if you step on the sidewalk, off the sidewalk funny, you roll your ankle, that would be inversion. Eversion, a little harder to do. That's where your sole of your foot goes laterally or goes outward away from the midline. So the ankle joint is very mobile. You can do that plantar dorsiflexion, but you can also move it medially and laterally just a tad. And those movements are called inversion if it's medial and eversion if it's lateral. And then we have protraction versus retraction. And these are very simple. As you can see, protraction is moving a body part forward. The two easiest locations in the body where we have this are in the scapular regions, the shoulder blade, and your jaw. Jaw's a little hard for me to do, but some of you can probably do it. So if we're protracting our scapula, probably a lot of you right now are protracting your scapulae. That's your scapular. If your shoulders are kind of hunched forward, and you're sitting over, texting or on the computer, and you're just kind of bad posture, that's protraction. That's when your scapula, or if you're punching or pushing something, you're protracting your scapula. It's moving forward. Retracting your scapula would basically be flexing your back muscles, your trapezius, rhomboid muscles, so you're bringing your shoulders, kind of trying to make your scapulae touch each other in the back, or what they call a scapular kiss. So you want more of that regarding scapula. You want more retraction, good posture, because protraction long term can cause some back issues later down the road. And then your jaw, it's the same thing. Some folks, like when we're chewing, this naturally happens. Your jaw moves forward and backward a little bit, but some folks are really good at jutting their jaw forward. The lower jaw, the mandible, you can jut forward. That would be protraction of the jaw. And then if you can actually tuck your jaw backward or closer to your cervical spine, that would be retraction. But once again, this is somewhat of a natural movement as you're chewing food or chewing gum. Your jaw slightly moves forward and backward a little bit as it moves up and down. Before we dive into these next two terms, I want to illustrate the protraction and retraction of the mandible. You can see in this picture here with the purple star, if you were to jut your jaw forward, that would be protraction. And then if you were to kind of just bring it backward towards your spine, as I said, that would be retraction. And you can see some of the other movements, pronation, supination, dorsiflexion, plantar flexion, and inversion, eversion as well. So the last movement that is considered special is elevation and depression. And based on their names, you probably already know what they are or what they're doing. Same thing, the most common or most easy locations to describe this as, or where they're on the body, are in your scapula, your shoulder blades. Scapulae is two scapula, and then your jaw, your mandible area. So if you were to elevate your scapula, you're just shrug your shoulders, right? Bring your shoulders as close to your ear as you can. That would be elevation. And then as you lower them or bring them down, that would be depression. And then same thing with your jaw. If your mouth is closed right now, your jaw is in elevation, or you're elevating your jaw. If your mouth is hanging open, you are in a depressed state, or your jaw is depressed. So you can see here in the picture, elevation would be a closed mouth, where depression would be more of an open mouth. And this last little picture here, we're not covering in the notes, but I do want to just bring this to your attention. One more special movement would be something called opposition. And this is the ability to touch each fingertip to the tip of your thumb. And that's where we get the term opposable thumb in humans. It's just that special movement where you can't do that with your big toe and your little toes, right? You can only do that in your thumb because of that special joint that we'll talk about. Now that we've covered the different ranges of motion, we can discuss the specific types of synovial joints. So as you can see here on the slide, we have uniaxial joints, biaxial, and multiaxial. And this is just describing how the joints move in how many planes. So we are three-dimensional beings, so we can move in 3 planes, right? We have an x-plane, a y-plane, and a z-plane. Or I can move forward and backward, left and right, up and down, right? 3-dimensional. However, some joints don't move 3-dimensionally. Actually, most joints don't move 3-dimensionally. So first things first, if we have a joint that is uniaxial, all that means is it only moves on one of those axes. So it either only moves on the x-axis and not y or z, or it only moves on the z-axis and not x or y. And a perfect example of this is your elbow. Think about your elbow. All your elbow can do is really bend and straighten, and that's it. When we're talking about pronation and supination, remember the holding the bowl of soup and then pouring it out? That's different. That's not your elbow joint. That's actually that radial ulnar joint, specifically the proximal radial ulnar joint. So the elbow's job, the only thing the elbow does is bend. Kind of works like a hinge, and you're going to see that on the next slide. We actually do call it a hinge joint. Another example of this are the interphalangeal joints of your fingers and toes. So I'm not talking about your big knocking knuckles or your punching knuckles more specifically. I'm talking about the very tiny parts towards your fingernails. If you were to be hanging on a cliff or hanging on a bar, think about how you would be gripping that. If your grip was starting to fail, you'd bend your fingers. So if you just look at your fingers and not your metacarpals, all your fingers can really do is bend and straighten, flex and extend. So those are examples of uniaxial joints. They can't really move side to side. When your fingers start moving side to side, you're getting the metacarpals involved. And they can't really move superior inferior. Really, they just bend and extend. An example of a joint that moves in two of the three planes would be a biaxial joint. And we have a few of those. Anytime where you see a condyle, for example, the mandibular condyle fitting in the mandibular fossa, or the occipital condyle, those are great examples of biaxial joints. So based on the shape of the condyle, they can move in multiple planes, but they can't move in all three easily. For example, your occipital condyle. Your occipital condyle helps you move your head up and down as if you're saying yes, but it does, and it also just a little bit of superior inferior movement and lateral flexion, but it doesn't help you rotate at all. Rotation comes from a different joint in the upper neck. So saying yes is using the occipital condyles, while saying no doesn't really involve them that much. So we're missing one of those axes. And then if we have a joint that has all three axes, x-axis, y-axis, z-axis, we can consider that a multi-axial joint. So a perfect example of this is your shoulder. Right, you move your shoulder in all three planes. You can move it X, Y, and Z. You can move it forward, backward regarding flexion. You can AD and AB duct your shoulder in many different planes. You can also rotate your shoulder, medial rotation, lateral rotation, or as we learned, retraction and protraction. So depending on how many planes the joint can move, we can classify them in these three ways: uni, bi, and multi-axial. So on the next few slides, we're going to give you some specific examples. Let's first discuss the uniaxial joints. So as you can see, there are three examples here of a uniaxial joint. We've already talked about a couple of them. First one is called a hinge joint. And a hinge joint is just like it sounds. It works kind of like a door hinge, or hinge on a door. If you open up your closet door, the door only moves in two directions. It opens and it closes, opens and closes. It doesn't really move side to side, hopefully, and it doesn't move up and down, hopefully, right? So examples of a hinge joint, we mentioned the elbow in the previous slide. We also mentioned the phalanges by themselves. And your knee is a great hinge joint as well. Just bend your knee and straighten your knee. That's really all your knee does. Your knee doesn't really help you with rotation. It's very, very subtle. Try standing on one leg and spinning without moving your one leg, your foot on that one leg. It's almost impossible. It's very, very hard. So really the only job of the knee is flexion and extension, bending and straightening. So we're talking one axis out of the three. Another example would be a pivot joint. We've talked about pivot joints before. We talked about the radial ulnar joint helping us with the pronation and the supination, bringing our palms up towards the ceiling or putting our palms down towards the floor. That's considered a pivot joint. Another example of the pivot joint we mentioned earlier is our upper neck. That top bone in your neck, C1, and the second bone, C2. helps you say no, helps you rotate to the left and rotate to the right. So all that joint does is rotate. It doesn't help you say yes, it doesn't help you bend to the side, it just helps you spin around one axis. And then the last one are those gliding, sliding joints. These are also I want to make note, or make you make note of, that these are also known as a plane joint because they exist on one plane. So a gliding joint, a sliding joint, a slipping joint, also known as a plane joint. And once again, these are found between your ankles and your wrist, those bones, those carpal bones and those tarsal bones, and also found between the superior and inferior articular facets, those processes. A facet is a process in the spine. So it's the same thing as saying superior articular process, superior articular facet. So once again, not a lot of motion, not a lot of movement. It's just kind of this gentle sliding, gliding. Really, these joints work as a whole. Your spine, when it bends as a whole unit. When you move your wrist or your ankle, the whole ankle or wrist are moving together. So it's very subtle movement between these. So hinge joint, pivot joint, gliding joint, all one axis out of the three. With the biaxial joints, you can see we have two examples. We have something called a saddle joint, and then we have the condyloid joints. Now, saddle joint, you probably have never heard it before. It's very rare in the body. It's only found in one location, and my drawing is not really going to do it justice, but it actually looks like a saddle joint. But it's a saddle sitting on top of a saddle. So I'm going to kind of draw this concave looking structure here. And then I'm going to draw this structure here. And I'll show you a better picture in 2 slides. But it can, because of the shape, it can move in multiple directions. It can move this kind of left to right, but it can also move this way as well. Versus a condyle, where we learned with the condyle and the fossa, if you have a fossa that's just an indentation, the condyle just fits right inside of that fossa like that, right? And it still allows for both movements, but the saddle is a little more unique. It just gives us a little bit more flexibility, more range of motion. Once again, picture coming up shortly. So where is a saddle joint found? Only one place in the human body where you can find the saddle joint. And it is the carpo-metacarpal joint of your thumb. Let me say that again. Carpo-metacarpal joint of the thumb. So it's where your wrist meets the metacarpal that leads to your thumb. So it's not actually your thumb finger, but it's where your thumb starts, if you will, with the wrist. And once again, this is what gives us that opposable thumb action. Think about your thumb compared to all your other fingers and toes. Your thumb can move in multiple directions with just a lot more flexibility. So you can see the movements are flexion and extension. That's one plane. And then we can also abduct and adduct. That's the second plane. So you get 2 planes, and therefore this is called a biaxial joint. And you can see with the condyloid joints below, same thing. It's just condyloids or condyles typically fit into a fossa. A little less range of motion, but same thing. You get the same types of motion. And once again, we saw this with the temporal mandibular joint, the mandibular condyle fitting in the mandibular fossa, the occipital condyle fitting on the first bone of the neck, that kind of thing. And then last but not least, we have our multi-axial joints. And the only type of multi-axial joint that can move in all 3 planes, that's what multi means, is the ball and socket joint. And the ball and socket joint sounds just like it is. It's just a ball, literally. Picture the head of your humerus fitting in your shoulder socket, or in this case, the ball of your femur, the femur head, fitting in the acetabulum. So it's literally a ball going into a socket. So really we only have these in your shoulder and hip joints. And if you take a look at the motions below, we have flexion extension, which is one plane. We have our abduction and adduction. That'll be a second plane. And then our third or multi-plane, which makes this multi-axial, is rotation circumduction. So multiple directions, multiple planes, only found in the shoulder and hip joints in your body. Okay, really great slide. I would encourage you to take a look at this because this is way better than my drawings. So you can see all the joints that we discussed. First, let's talk about the uniaxial. I'll do these in red. You have your hinge joints. Once again, found in the fingers and the elbow. You have your plane joints, also known as your gliding joints, found in the intervertebral area where you have the articular facets or articular processes, also found in the wrist and ankle. And then you have your pivot joints, found in the radius ulna area, also in your upper neck. That helps you say no, shake your head left and right. So those are the uniaxials. The biaxials here in green, this is the saddle joint, and you can see much better drawing here. It's kind of looks like a saddle sitting on another saddle. So it's a upside down saddle sitting on a saddle, and what the overlap of this articulation creates is movement in multiple planes. It lets that opposable thumb move and have great range of motion. And then the second type of biaxial joint are the condyloid joints, and you can see a condyle process just fitting inside of a fossa there. And last but not least, we have the ball and socket joints, and literally just it's a ball in a socket. So that would be our multi-axial illustration. So make sure you know which ones fall under which category. We have 3 under uniaxial, the pivot, hinge, and plane. And then we have the saddle and condyloid under biaxial, and then the only multi-axial one is ball and socket. Okay, for these last few slides, we're just going to talk about specific characteristics of some unique synovial joints. And as you can see, the only ones we're going to talk about are the shoulder, hip, and knee. Let's start with the shoulder joint, also known as the humeroscapular joint. Once again, it's just where the humerus meets that glenoid fossa or glenoid cavity of the scapula. So important characteristic to know about the shoulder joint is this is by far the most movable diarthrotic joint. Now, when we're thinking about most movable, we kind of only had 2 options because we only had 2 multi-axial examples, right? We had the shoulder joint and the hip joint that had that ball and socket. So basically, when we say most movable, we're comparing the shoulder to the hip. And although the hip is pretty movable, the shoulder is the most movable. And the reason why is because that glenoid fossa, or that glenoid cavity, is so shallow. And what that does is it allows that humeral head to move and have more freedom. Versus compare it to the femur head and the acetabulum. The acetabulum is really, really deep, so that head of the femur fits in that socket very deeply. Now, while it's still a ball and socket, because it's so deep, it can only move so much. So here's a really important principle regarding joint mobility and stability. There's an inverse relationship. So the more stable a joint is, I'm going to put STA for stable, the less range of motion the joint typically has. So range of motion, ROM. So the hip, when compared to the shoulder, the hip is a little bit more stable, and therefore we have a little less range of motion. So if we're going to dislocate a shoulder versus dislocating a hip, it's a lot harder to dislocate a hip because it's more stable. That acetabulum kind of protects it. But this is also flipped. If I have decreased stability, I can have increased range of motion. Or you can flip it. If I have increased range of motion, I have decreased stability. So your shoulder, raise your hand to ask a question. Take your right hand and slap your left shoulder. I mean, you can move it and put your arms behind your back. You can move your shoulder in so many different directions. So it's got a lot of range of motion. Problem is, with all that range of motion, you can injure this bad boy pretty easily. Just ask anybody above the age of 30 or 40. Rotator cuff tears, very, very common. Arthritis, very common, all sorts of issues. So you can see structures that do give the shoulder a little bit of stability. We do have ligaments, we have muscles and tendons, which I'm going to cover on the next bullet point, and we also have bursae. We have multiple bursae inside the shoulder joint that does give it some stability. But because that glenoid fossa is so shallow, because it's not really a big pocket, we do have a lot of freedom to move our shoulder. And therefore, very susceptible to injury. As we get older, the main thing that gets injured is the rotator cuff. And the rotator cuff is a collection of 4 muscles that help protect the shoulder joint. And it helps you move in very unique movements. One of them is just simple, is more of a flexion, but the other 2 are a specific type of rotation. Or the other 3, excuse me, are a certain type of rotation. And if these are damaged, or if the tendons are torn, a lot of times you will lose shoulder function without a surgical or a long time in physical therapy. So because we don't have a lot of stability, we have great range of motion. It's kind of a trade-off, right? If I'm really, really good at yoga, if I can throw my foot behind my head, awesome, I'm really flexible, but I probably can't run that fast because my muscles are too stretched out. But if you think about a football player or a soccer player or a sprinter, their muscles are generally a little tighter. They probably can't put their foot behind their head, but their muscles can generate a lot of force. So you can either have strength and flexibility, but neither extreme. Now, some folks are good at strength and flexibility, right? They're stretchy and they're strong, but you can't maximize both. One has to suffer if the other one's going to be great. So this was the shoulder joint. On the next slide, we're going to cover the hip joint and talk about how the hip joint's a little more stable. So the hip joint, also known as the coxal joint, and remember where we get that term, it's the os coxae, is the collection of those 3 pelvic bones, the ilium, ischium, and pubis. But generally speaking, you'll just hear the term hip joint. This is the most stable diarthrosis. Once again, as I mentioned, it's very hard to dislocate this thing. If you dislocate your hip joint, you either have some serious osteoporosis going on, or you were in a really bad trauma. You were in a nasty car accident, terrible skiing, snowboarding accident, or I don't even know. I mean, you can have your buddy pull on your leg as hard as you can. You're not going to dislocate that hip. You have to maneuver it in a very certain angle and generate a lot of force. It's very hard to do this. And once again, the reason why is that acetabulum is such a big pocket. So that head of the femur is pretty much buried inside of that pocket. And then, of course, we have a whole bunch of very strong ligaments connecting the femur to the ilium, ischium, pubis area, making that even stronger. But just to reiterate our point from the last slide, because it's so strong, it's more limited in its range of motion. It's not as mobile, right? I can't move my hip as well as my shoulder. So there is that trade-off. And then last joint we're going to discuss is the knee joint, and the knee joint is also known as the tibiofemoral joint. So obviously it's where the tibia and the femur meet. And yes, we do have other bones associated with this, right? We do have the patella bone, and we do have the fibula bone where some of your hamstring muscles do attach to. However, what's actually doing the motion of flexion extension, the knee joint motion, are these 2 bones, the tibia and the femur. So this joint is very, very special because it's got a lot of crazy things going on, and it also has a lot of stress on it. right? So you think about your hip, you think about your knee, you think about your ankle, all the trauma you do to it every day, walking, going up and down the stairs, jogging, running, jumping, whatever. And yes, the ankle does take a lot of stress, and so does the hip. But the only joint out of those three in your lower limb that has the meniscus, that has that extra fibrocartilage for extra padding, is the knee. So because it's the most weight bearing, we need that extra protection, that meniscus. Now, this is kind of a contradiction, right? We said the shoulder is very, very easy to injure due to the crazy amount of range of motion. The knee is often the most frequently injured, though. So I would say the shoulder is the easiest to dislocate. The shoulder is the easiest one to pop out of socket. But just generally speaking, injury regarding a meniscus tear or a cartilage tear or a ligament issue or some kind of sliding or tracking issue with the patella due to muscle weakness, you can have a lot of bursitis. You can have a lot of things go wrong with the knee. So it's often very frequently injured. And the reasons why you can see below. The condyles of the femur and the tibia are kind of unstable. If you remember the medial and lateral condyle of the tibia, they weren't really your typical condyles. They're kind of flattened. So you have these two rounded surfaces on the femur, and they fit on this kind of flat surface, which gives it some range of motion. That's good. But once again, it also makes it unstable. We also have very little muscle over the joint. Yes, we have our very big quad muscles and our very big hamstring muscles that move the knee, but where they insert, it's a very, very tiny portion, and they actually don't even insert, well, they insert on the tibia and the fibula, but it's a very small portion where they insert on the bones. So it's not a lot of muscle actually covering the joint itself. So because of that, we do need a lot of help. We need a lot of ligaments inside of this area. And so that makes it also a little more complicated. So for example, with your elbow, it's really simple. Elbow's a hinge joint, and you have a ligament on the medial side of your elbow. You have a ligament on the lateral side of your elbow. With the knee also being a hinge joint, you would think it's the same thing, right? We have a medial ligament on the knee, and we have a lateral ligament on the knee. And yes, that's absolutely correct. But we also have other ligaments. We have an anterior ligament I'm going to introduce. We have a posterior ligament. We also have another one. So a lot of ligaments to help with this stability. But as anybody who's ever torn an ACL or a PCL or an MCL knows, that it's kind of easy to do so. You don't exactly have to be in a crazy accident to tear an ACL. You can just step funny sometimes, unfortunately. This slide is just showing you how complicated the knee joint actually is. You can see just how many things are labeled on this picture. One thing I want to point out, though, is this picture on the right. And what we're looking at here is a transverse cut of the knee joint. So basically, we cut your, let's just say we did a knee amputation or an amputation at the knee, and we cut your leg off. And now we're looking down or up into the knee capsule. So we talked about a typical synovial joint that has the fluid-filled cavity, and then the ligaments are on the outside of that fluid-filled cavity. And that's the case in every single joint in the body, pretty much, except the knee. As you can see, you have ligaments inside of the joint cavity here. And that's why if anyone's ever torn an ACL or a PCL, you have some serious stability issues here, because this is actually inside of the cavity itself, inside with that synovial fluid. So it just makes it even more complicated when you have any type of knee trauma, very different than any other type of joint. So you can see how, just similar to other joints, what stabilizes them, we have a capsule and we have hyaline cartilage, but we also have that fibrocartilage, which remember we call menisci or menisci. So you have two meniscuses, if you will. You have a meniscus on the medial side and a meniscus on the lateral side of each knee. So technically you have 4 menisci in your whole body, 2 for each knee. We also have all of those ligaments that you can see at the bottom of the slide, and then we're also going to have those muscle tendons as well. We also have bursa that we talked about. So the knee tries to do the best it can to stabilize itself with how goofy and funky it is. But once again, it is very common and very easy to injure it because of the positioning of the joints with the tibial condyles, and just because it's weight bearing. It's the majority of our weight bearing. So you can see a few ligaments I want to point out, the ACL and the PCL. Some of you may have heard of that before. What this does is it connects the anterior tibia to the posterior femur, and basically this helps your knee not to hyperextend. So if you extend your knee fully, lock out your knee, make your legs completely straight, your ACL tightens and contracts to the point where it doesn't allow the tibia to slide any more further anterior, so you don't dislocate the knee, or what we call hyperextend it. So when the knees actually go backwards, if you're standing straight up and your knees are locked and your knees go backwards, that could lead to ACL trauma. A PCL does the complete opposite. A PCL connects the posterior tib to the anterior femur, and that helps us make sure that we don't go too far with the sliding of the tibia and femur. Makes us go too far posterior. So when you're flexing your knee, it's making sure that your tibia and your femur aren't slipping off of each other. So very, very important regarding anterior and posterior movement of those bones. And then you can see other bones that we have. We have the posterior tib-fib ligaments near the meniscus. We have a transverse ligament as well in the anterior part of the meniscus. And then we have collateral ligaments, which are typically what we think of with ligaments and synovial joints. We have an MCL, it's called the medial collateral ligament. We also have a LCL, lateral collateral ligament, that connects the femur to the fibula. So all of these ligaments try to contribute to knee stability. But if you tear one or two or sometimes even three of these, depending on the way you got hit or the way you fell, that can be a very long rehab process. So take care of your knees. Remember Wolf's Law from chapter 6, right? If you strengthen it, stuff gets better, right? If you don't use it, you lose it. So if these muscles, tendons, and ligaments are weak, do strengthening exercises to make them stronger so you don't have knee issues later on in life. All right, y'all, that is it for the joints chapter. We will start the muscles next. So let me know if you have any questions, and study well. I will see you next time.